try to cover as much as I can in this limited time, but first of all, I would like to give you two terms that are very important. One is the therapeutic hypothermia, in which the body temperature is lowered from 32 to 34 degrees Celsius. The other newer term that is being used these days is known as targeted temperature management. And in this way of treatment, the goal temperature is 36 degrees Celsius. We are using Celsius scale because it's easier to target these patients as compared to Fahrenheit scale. The difference in the therapeutic hypothermia and the TTM, or targeted temperature treatment, is the group of patients we are treating. So any patient who had cardiac arrest should be evaluated for these two modalities of treatment. However, if the patient is following commands lightly, if the patient does not have evidence of cerebral edema on the CT scan of the head, if the patient does not have any EEG changes like seizure spikes, TTM can be done. However, in clinical practice, we see that a patient who had cardiac arrest, a lot of things going on. As a critical care physician, when I attend to these patients, I try to do one assessment. And if the hospitalist, as a doctor in the hospital, I think you can do it too. I quickly go to the bedside after they're intubated. They have a return of spontaneous circulation. I give them a sternal rub and just ask them, for a command involving higher brain function, like wiggling your toes. If I do that, Mr. John, wiggle your toes, and he's wiggling his toes, that is the best test you can have on the bedside. And that patient would be beneficial for TTM as opposed to therapeutic hypothermia. If a patient is not able to follow any commands and maybe moving extremities reflexly, that does not count, or they have any evidence of cerebral edema or EEG changes, he should be treated with therapeutic hypothermia. Again, the difference is the goal temperature. Again, I will repeat, 32 to 34 for therapeutic hypothermia, and for TTM it is 36 degrees Celsius. I put a slide, a point at the bottom. Risk of death increases for each degree over 37 degrees Celsius during the first 48 hours. This is equally important to understand for all of us, that if a patient had cardiac arrest, for whatever reason you're not able to offer them these treatments, the prevention of fever is imperative. Because we have data that these patients, if they have fever, they will have poor outcomes. So fever is a no-no. Indications of therapeutic hypothermia, I briefly went over these points. That any patient with cardiac arrest had return of spontaneous circulation, they should be evaluated for this. And if they are doing purposeful movement, and on occasion you will find a patient who had cardiac arrest, mostly the patients who had cardiac arrest in the cath lab, or in the hospital. You do the CPR right away, they wake up and you can see them that they are awake, they are following commands, and that is your clinical judgment. Those patients will not need the treatments, including TH or TTM. The contraindication, the absolute contraindication is the do not resuscitate status. And one of the other contraindications that we talk about is bleeding at a non-compressible site. However, those patients may be considered for TTM treatment, that is the targeted temperature management. Interestingly, these modes of treatments have been used in patients who are pregnant, and most of them are actually hemodynamically unstable. So this is not a contraindication. It can be used in the cath lab, and it can be used after thrombolytic treatment. However, the risk of bleeding is increased in patients who have received thrombolytics. But again, I would like to give a little bit more emphasis that a patient who had cardiac arrest, the number one reason they die is the neurological outcome. So even if they have a risk of bleeding, the risk-benefit ratio favors TH in patients who had thrombolytics. Timing and duration, there are lots of data on that. I mentioned you, and I have put these numbers deliberately multiple times in my presentation, so we may take them home, 32 to 34, and then 36. So it should be done as soon as possible for 24 hours. Okay, that is the number to remember as well. It's for 24 hours. However, there is data that patients who are cooled for up to 48 hours, in some studies up to 72 hours, may show some improved outcome. However, the risk of complications is increased. If there are any pediatricians in the room or neonatologists, they know that in neonatology we do it up to 72 hours, but not in adult population. Adult population we do it up to 24 hours. Sooner the better. You know, we should start it as soon as possible. Cooling a patient for less than 6 to 12 hours, unlikely to be effective. This is an important point to understand. So you started a patient on hypothermia, and the patient is getting a little bit unstable. You know, you are having challenges in maintaining their blood pressure, their oxygenation. If possible, stretch that up to 12 hours, because there is data that confirms that they have benefit if you can pull through 12 hours. If you have to abort it before 12 hours, then there is no evidence of any benefit. Intra-arrest hypothermia is not currently recommended. However, it is important to know that when they have when they have cardiac arrest, they do have hypothermia, some degree of hypothermia. So sometimes, you know, you get a patient in the ICU from floor after cardiac arrest, and the nurses are putting bear huggers and trying to rewarm them because their temperature is 36, should be a no. Okay, we should not rewarm them actively. Methods for implementing, there are two methods, and they are very simple to understand. One is the intravascular, and the other is the surface cooling. Surface cooling could be used by the devices available, and those devices, we have little machines, you set the temperature on that, and they do their job. Intravascular could be used with a catheter that is just flowing very cold fluid inside the catheter, or you can infuse cold saline of 4 degrees Celsius temperature. So as a rule of thumb, 1 liter of 4 degrees lowers the temperature by 1 degree Celsius. And you can pressure bag it in like 15 minutes. And you know, it is a very quick way. The only point we have to remember here that they should not have CHF. If they have CHF, the chances of pulmonary edema, congestive heart failure, kind of puts you in a difficult situation, and you have to do the diuresis. And in those patients, I personally do not recommend using cold saline, but it's a very effective way of getting the temperature down quicker. Most of the time in clinical practice, both the methods are used. We use the surface method and the intravascular method. Now, once the patient is on the cooling device in the hypothermia protocol, the main problem, if I have to list, include the hemodynamic instability. Oxygenation mostly is not a problem for them, but hemodynamic instability and electrolyte management and shivering. So shivering, as we all know, is a protective mechanism to fight the hypothermia. So we must have to stop shivering. The ways to stop shivering is sedation, and what I'm talking about is good sedation, not just like 2 milligram of Versed. We want to use like good amount of sedation. The best regimen that I've seen is propofol and fentanyl. Propofol you can use up to 50 mics, and fentanyl you can use up to 150, maybe 200 mics. If the patient is hemodynamically stable, you can add Versed to it. Well, most of the patients, as I said, do have some hemodynamic instability. In those patients, you can use Versed and fentanyl, that works. However, this will not be efficacious in all the patients. So if the patient is still shivering, you are maxed out on your drips, then you have to block them. The neuromuscular blocking, has its pros and cons. The biggest thing to consider is if you block them, they may have seizure that you cannot see. Okay, but it's a clinical challenge, and I typically involve neurology services, in these patients. Typically, we try to get a train of 4 2x4 for the paralysis, and that is a simple test you do. You put like a little machine on the ocular muscle, and you give like 4 little stimulation, and they are like 4 twitches. So you increase the blocking agent, and there are 3 twitches, and you give more medicine, and you are giving now 4 stimuli, and you're seeing 2 twitches. That is called a train of 4 2x4. That is optimal level of neuromuscular blocking in these patients. There are other medications. This medication I can never pronounce. I try again. Dexmedetomidine. The problem with it is very expensive and causes bradycardial hypotension. We do not have available in our pharmacy. Monitoring and rewarming. The gold standard probe for temperature monitoring is the intravascular probe. However, we have the esophageal probe, the rectal probe, and we have the bladder probe as well. In the bladder probe, you have to see that they should be making at least 0.5 ml per kg of urine, so that the probe which is floating in the bladder, can pick up the temperature. We typically use esophageal probe, by the way, and it works good. Axillary is a no-no. We cannot use axillary, temperature monitoring. Rewarm gradually. I put like 2 stars there, and this is also very important to understand that if we are rewarming the patient, and we rewarm them fast, so we do more harm than any good to the patient. Okay, the goal rewarming is 0.25 to 0.2, no more than that. But if you go up to like 0.5, that's okay too. No more than 0.5 degrees Celsius per hour, they should be rewarmed. If they are rewarmed faster than that, that is actually harmful. As I said, if you cannot control this part, do not start hypothermia. The rapid rewarming causes electrolyte abnormalities like hyperkalemia and the cerebral edema, seizures. The rate of rewarming can be increased by adjusting the temperature. Adverse effect, just to quickly remember, bleeding and infection and electrolyte imbalances. There are some issues with blood glucose monitoring. If they are hyperglycemic, you can use the insulin drip, and that works pretty good. We don't have to be very tight on the glucose control. 140 to 180 is a decent target to achieve in these patients. Evidence, there are multiple trials I have mentioned here. The most appropriate patient is a VFib arrest or the pulseless VTAC. However, 2010 ACLS guidelines recommended to do hypothermia on all cardiac arrest patients, and now in 2015 they have again recommended hypothermia on all patients with cardiac arrest who had a run of spontaneous circulation. Quickly, at our center, we started that program in 2013, and there are challenges we had to face, including the staff training. It should be 1:1 in ICU. It will be cruel for the nurse if you give more patients, including a hypothermia patient. Equipment buying, not very expensive, but you have to talk to your administration. ER participation.